Good afternoon, everyone. I very much thoroughly enjoyed the opening session this morning. I think it really set the scenes for this session, and thank you for coming after lunch to listen. One of the things that said in the opening session this morning, there was a lot of talk about the priorities for the critical care network in Victoria about sedation and delirium. The reality is that this is not just the critical network in Victoria. Delirium and sedation is really a global agenda, and it's an agenda that attracted a lot of attention for a lot of people and took a lot of effort and time for a lot of people. The PADI's guidelines, which was referred to by Narina this morning, which is the pain, agitation, sedation, immobilization, and sleep, will be released by the Society of Critical Care Medicine in a couple of weeks in critical care medicine. Quite an exhaustive guidelines, and I'm sure you will have a lot of thoughts on that. Our SPARS trial, which was also mentioned this morning, concluded in February, and early next year will be the first public presentation of the results. All that together will really give us a lot of information, a lot of guidance, a high-level one, high evidence one, to actually let us know what we do. What I wanted to do in the next 20 minutes or so is to take you down the path how delirium fits in from a safety and quality perspective. Having this conference is pretty much a safety and quality conference. Now, we all know that, when it comes to deteriorating patients, we think of them like people who swim, and they always have to swim between the flags so that we know when something goes wrong, we can rescue them. That does occur for deteriorating patients where things are easy to measure and easy to see. We rely a lot on vital signs, the yellow zone, the red zone, this zone, and it's quite easy to see. However, when it comes to things like cognitive impairment or mental illness or delirium for that matter, things are very different. And things happen where, with a delirium patient, there's no flags. Suddenly you just see a red card, and it may be too late by then because somebody will be on the ground, somebody will be damaged, and it's too late by that time. So we need to find a way where we can actually, whether through a chopper or through a little drone or something, we need to find those people who choose to swim in the middle of the night outside the flags unnoticed and stop them from drowning or causing harm. So the main reason for the need for this is that we as clinicians, whether we're doctors or nurses or light health, we used to think about things in terms of physiological parameters. So we're very familiar with having a saturation that will, reflect a reduction in oxygen and hypoxia. Very familiar with things like, oliguria or a creatinine rise where there's a kidney injury happening. Very familiar with things like, doing a troponin or doing another blood test to tell you that it's something that is going wrong. Unfortunately, when it comes to delirium, we got none of that. We don't have a physiological measure. We don't have a biological marker. We don't have a way of assessing what's happening there unless we systematically engage with the patient in a question and answer and look what they've been doing the last few hours and what they are at that point in time to detect whether there is something that is going wrong or is about to go wrong. So we are already disadvantaged by the way the physical signs when it comes to delirium is really there or not there. You've got to have to go and look for it. It's not something that you go at 9 o'clock in the morning and you look at the power chart on your computer and suddenly come a test that say this patient is delirious. It is not like that. And that's a big problem. So delirium itself is very, very common, and that's really, when you think about it, if I tell you that every second patient in your ICU is going to have kidney injury, you stand up and say, my God, I've got to do something about it. Now, when it comes to delirium, it is that common. Every one of two patients, every second patient in your ICU is likely to get a delirious episode while they're in ICU. The problem, we don't see it, is that the majority of that delirium is a hypoactive delirium. It happens insidiously. We don't know about it. The only way we know about it is when it happens at the nose test. When something goes wrong and the patient becomes agitated, or they develop a mixed delirious state of between agitated and hypoactive delirium, where we actually say, oh, by the way, he's got delirium, let's try and do something about it. Now, this is data from the very early SPICE data, where we tried to look in sedation practice across Australia and New Zealand in preparation for the study which we've just completed. In this study, we found that exactly what we expected. 50% of patients scored a delirious episode at one or another time during ICU stay. What was more staggering is that the more the patient is ventilated, the more they are in ICU, the higher the likelihood of them getting delirious. For patients who are in ICU for more between 8 and 14 days, they're still about 50%. Once you pass to 2 weeks in ICU, you are almost guaranteed to get a delirious episode. So it's very common, and it's problematic. This is not just data from Australia and New Zealand. This is, again, as I said before, it's a global agenda. We've done the same study in Malaysia, and we find almost exactly similar results. If you're in ICU for longer than 2 weeks, very likely you will get a delirious episode. If you're ventilated, your delirious risk is at least one of every 2 patients. So it's very common, and we see it regularly, almost on a daily basis. And that also reflects the interest in delirium in North America, in Europe, everywhere. So truly, delirium and sedation is an agenda that's dominated the world for a long time. Gideon will be talking about the pathophysiology and a lot of stuff that he's done about delirium, which is really great for what Gideon has done, and he will talk through that, is identifying the final common pathway of what actually happens. But before that final common pathway occurs, we've got to remember that in ICU, pretty much like when a trauma happens on the road, we are aware of what could possibly be the secondary injury. Secondary injury of hypotension, hypoxia, bit of raised CO2, and then the brain gets a second hit. I want you to think about delirium as a secondary hit or even a tertiary hit for a patient who is in ICU. They've got the hit of their underlying disease, they got the problem with all the hypoperfusion and all the drugs we pump into them, and then they get the third hit of getting a neuronal delirium, where it will lead eventually into something, whether either a neuronal death or otherwise. The delirium itself is driven by many of what we know as the delirium neurotransmitters. It is pretty much like any other mental illness, whether it's depression or schizophrenia. There is a lot of imbalance between multiple neurotransmitters that we see, and this all being done with animal models that produced nice animal models to actually replicate and measure all these levels in the blood, and show that this is what actually happens with delirium. So I won't spend much of time on this, because this is really something that I hope Gideon will cover in his talk, and he's thumbing up, so it's all going to happen. Now, I know that I'm probably preaching to the converted here, because you're all here to listen to delirium. You're all aware that it's bad and things happen. The people I'm worried about are the masses out there in our hospitals and in our intensive care units who still think of delirium as something that it's the devil we have to live with. It happens and then it goes away, the patient becomes okay, and then they discharge. Unfortunately, this is not the case. And delirium has extremely bad short and long-term consequences. I'm just going to share some of this with you. Now, this is a delirious patient in ICU. Now, you could probably say, well, why are you putting this picture there? But if you look closely, you can see that this patient has a scissor in his hand. Okay? Now, this patient was completely fine 15 minutes before the bedside nurse approached his bed to do the simple observation. And like a good nurse, she had a scissor in her pocket. And the patient took the scissor, said, I'm going to cut your throat with this scissor. And then she stepped back, called for help, and then within minutes, this is what happened. You can imagine if that scissor was around here or around there, would have been an absolute disaster for that patient. Now, this patient was not delirious just 15 minutes before he did this. But this is what delirious patients could do. The damage they can do to themselves, to the staff, is incredible and can be from A to Z. Now just think about what the relatives of this patient will be thinking if they were at the bedside seeing this happening. It is as traumatic to the relatives and to the patient carers as they are to the people who are in the unit and to the patient themselves. This data here from a patient who was a boxer, a big boxer, came with this, admitted to ICU, to a hospital where they still do abdominal x-rays, of course. And the surgeons decided, we're going to wait on this. They sent him to ICU. Let's get him metabolically fixed before we fix his abdomen. So he got admitted to ICU, and he was fine. Except that in the middle of the night, he just gone completely delirious. The bedside nurse called for the resident to come and see him. And the resident was a petite, lovely resident. And as she approached him, without notice, he practiced his boxing. And she ended up flying across the unit with 2 weeks sick leave and a lot of, stress damage to that person. So it's not something that we should take, lightly. It's something that is really, really serious business. Okay, having told you that, you're going to ask me, okay, what are we going to do about it? I think from a safety point of view, it is absolutely essential that we, number one, recognize it, but more importantly, we don't make it worse. We acknowledge that this is a problem that we should manage effectively and deal with it as such. In terms of screening, there are multiple tools available. The commonest one that's really been used around for some time is the Confusion Assessment Method, or the CAM-ICU. The second one, which is also being used pretty much more on the Canadian side of North America, is the Intensive Care Delirium Checklist. They are both validated in mechanically ventilated ICU patients. The major difference between the two is that the CAM-ICU is a snapshot at one point in time. You come and see the patients at 2 o'clock in the afternoon. That's the time whether they are CAM positive or CAM negative. It doesn't tell you whether they're going to be delirious at 6 p.m. that night or they were delirious at 6 a.m. that morning. The intensive care delirium checklist does not interact with the patient at all. It's up to the bedside nurse longitudinally over a whole shift to record what happened to the patient and then tally up the results and come to whether the patient has had whether the patient is delirious or not. So that's the CAM ICU. Most of you are quite familiar with. I won't go through it just for the sake of time. And that's the intensive care delirium checklist, where you tick all the boxes to come to a score, and if the score is more than 4, then you are delirious. The other tool that became a bit more available, and there's a lot more awareness about it, is the 4AT, which really is kind of a newer tool. We're not much used to it in ICU. There is currently studies that's looking into the like a comparison and validation between the 4AT and the CAM ICU to see how they both fare well. I take a different approach to this, and I say, instead of having to assess a CAM ICU or a screening delirium checklist, we really need to look at the patient ICU, because they are at very high risk of delirium in terms of cognitive wellness. There are some of the things that when I go to the bedside, when I talk to my registrars and residents, they're the things that we see the patients, we see the barriers for the bedside nurses, for the doctors, whether they're junior, even the senior doctors, in assessing delirium at bedside. It's where the patients are ventilated, they can't communicate with them adequately, their sedation level is deep, their barriers of understanding, why should I do this, is it bad for the patients, if I knew they're positive, what am I going to do about it, if I go and tell the doctors to do nothing about it as well. So in my daily, when I do my rounds on my patients, this is what I do. I don't do CAM ICU, I don't do delirium checklist, I don't do the 4AT. I do what I call a cognitive assessment for that patient. And it's really important that those patients get assessed systematically for pain, get assessed systematically for their eye contact and response, get systematically assessed for their attention span, and they get systematically assessed for their orientation. If you do that in sequence, it will take you like 2-3 minutes to do that, but it will give you a significant insight into whether that patient is delirious or not. One of the long-term impacts of delirium is increase in mortality. This has been talking about for quite some time, and if you look at the early data we've done in 2010, we've shown that delirium itself produce an increase in mortality and a prolonged ventilation time in those patients who are in ICU. Now, what we also found in that same study is that it is the duration of delirium that really matters. With every additional day of delirium, adding 10% increased risk of death for that patient. In addition, it adds significantly to their reduction in their cognitive function as time comes. This is data from Margaret Pisani, who also showed the same thing, that with increasing duration of delirium, there is an increase in mortality with time. The other side of the coin, which we've also recognized, is the interaction of delirium and coma. If delirium is bad, delirium and coma is terrible. And that's why if you have a patient who's delirious, the last thing you want to give them is deep sedation, because that is likely to give them that quaternary hit, not just the tertiary hit. And there's a lot of ways where we can give people coma and delirium. Coma and delirium is a very, very bad combination. And whichever way you look at it, the data from the sleep study from Gita Mehta from Toronto have show beautifully how coma and delirium compared to delirium alone or no coma or delirium significantly increase the duration of mechanical ventilation in those patients. Similarly, if you look at the mortality, patients who are delirious and comatose compared to those who are delirious alone or not comatose or not delirious has substantially higher mortality than those patients who are normal patients. So from a quality perspective, it is absolutely essential that we don't mix don't make things worse for those patients. This is the eCash approach, which we published in Intensive Care Medicine last year, where we intervene early, we maintain the triple C, where the patient is comfortable, cooperative, and communicating. We manage analgesia, sedation, and essentially patient-centered care systematically with those patients, aiming to produce a comfortable patient who is not comatose and not delirious. This is what happens with patients who are deeply sedated. This from the SPICE data. We showed that if you have a RAS that sits at 0, your chance of being delirious is about 8%. And you can see the U-shaped curve where if you +1 or -1, that delirium goes much, much higher. So the other thing which we should try and not use, and I say try because it's a culture, unfortunately, in our units, that when somebody is delirious, we rush to the restraints. And restraints has been shown by multiple studies, whether it's the sleep study or other studies, that delirium, that restraints are actually a risk factor for delirium. When you put patients in restraints, you're actually inviting them to be more delirious. I think Ronaldo will touch on the environmental parts of treating delirium, which is pretty much an ICU delirium-friendly environment. Now, for the sake of time, I'll just browse through this very quickly. Delirium and long-term impact is significantly bad. There is a significant increase in long-term cognitive impairment, which is shown beautifully by Pratik Bandarabandi in their New England Journal of Medicine data. And it also showed that, and that's the one that I wanted to show you, focus on, that the longer duration of delirium is the one that associated with most damage. So it is the duration of delirium rather than just delirium itself that really cause a lot of damage. There's currently a lot of data, work done by Sharon Inawa about the elective surgery and caring for the elderly, and it showed beautifully that the functional recovery in patients who are having elective surgery is significantly delayed up to 18 months if the patient gets a delirious episode in ICU. So, ladies and gentlemen, in conclusion, I want to tell you that delirium is very common. Unfortunately, it happens outside the flags. We don't know about it. It's very bad short-term and very bad long-term. A safety imperative for us, we have to predict who's going to get it. We have to recognize who got it. We're going to find a way of preventing it. In terms of a quality imperative, we need to know the consequences. We need to have an effective treatment modality to manage it. And we need to reduce the duration of delirium as much as possible. Most of all, we should do no more harm. Thank you for listening.